I started out with neurofeedback thinking that neurofeedback was what Len Oakes was doing in 1996. And I didn't know anything other than that. And then I realized that Len was kind of on the far fringe of what neurofeedback might be considered. But I saw when I was watching the EEG dominant frequency activity, I saw that there was some kind of pattern in the dominant frequency movement up and down the range of frequencies from 0 to 40. And that caught my attention, and I then started looking more closely at the nature of the pattern as it related to the characterological defense structure of the person who was being measured. And by characterological defense structure, I mean the way in which people who studied psychoanalytic psychotherapy in the neo-Reichian side of the tree, that we were thinking about how specific patterns of chronic muscular tension were correlated with specific patterns of psychological defense and characterological defenses, like denial, splitting, that sort of projection, projective identification. So what that led to was more and more of an understanding, at least on my part, that there was a way of understanding characterological armoring, which is what Wilhelm Reich talked about as those patterns of chronic tension in the body that were directly related to early trauma. That there was a way of understanding character structure as it manifests in the brain, because everything that Reich and the neo-Reichians and the people in body-centered psychotherapy, all they ever talked about was the patterns of muscular contraction, because that was a very binary type of system. But clearly, whatever was going on in the musculoskeletal system had to be driven by the central nervous function. So the question was, what is the analog to muscular contraction as it manifests in the brain, which is not a muscle? So there's nothing going like that. So what was it? And this was not a topic of discussion amongst people in psychoanalysis, because that's not what they were thinking about, but it was something I was thinking about from a neurofeedback point of view. So what that led to was more and more understanding that there was something going on in the brain that was directly related to the psychological state of that person and their characterological defenses. So we'll leave that for there. Then people that I had been working with for several years, because again, I was doing long-term intensive psychoanalytic body-centered psychotherapy in the bioenergetic tradition. I don't know how many people know about bioenergetics, but it was the American version of Reichian analysis that was developed by Reich in Europe. So my training led me to think along these lines, but I was working with people who then came in, and one guy came and said, you know, I'm doing really well, things are great, but you know, sometimes things don't click. And he did this. And my training was to say, what is this? What's this in English? Well, you know, sometimes I have to read things 3 times. Sometimes the letters move around on the page. You know, I get a headache. And I was like, what? Did you get a head injury? Did you get hit in the head? And I said it like that. And the guy's like, you mean a car accident? No, I never had a car accident. So then I had to sit back and go, that's not what I asked you. Did you ever get hit in the head? Really? No kidding. Oh, I mean, you know, I fell down the basement steps when I was 3, and Johnny hit me with a baseball bat, and I hit a brick wall when I was 12. And I'm like, you're not neurotic. You're brain injured. Now what do I do? And it was that moment of being completely de-skilled and realizing, you know, Marvin, guess what the third question on your intake is from now on? So that led me to then go back through my entire caseload and ask that question. 70% of my caseload had a diagnosable head trauma. Oh my God, what have I done? So it became clear that I couldn't get from here to there for real anymore without understanding what was going on neurophysiologically. So I retooled myself, but while I was doing that, I made a phone call to Len. Do you have a gizmo that I can, like, do you have, what can I do here? You do biofeedback stuff. What do I do? Meet me in Florida. Okay, I go to Florida to the, remember Winter Brain with Rob Call?
Yep.
So I go to Winter Brain, and Rob, you know, they do all this stuff. Len and I lock ourselves in a hotel for 3 days, and he shows me Lens, what was originally, what now is called Lens. I go back to my practice with a Windows 95 tower, these blinky glasses, an EEG. It's like crazy. I go back, I do what he showed me with these people, with this guy specifically. 6 sessions later, he comes back and goes, well, that's the end of that. What do you mean? Oh, it's stopped. It's done. It's not happening anymore. What? Really? Yeah. Okay. So I just accepted it and put it in the closet. Then somebody came in with a car accident, and I was like, I know what to do with you. I got it out. I did it 5, 6 sessions with her, no problem. So I'm like, okay, so this is what you do for head trauma. Except then the 2 of them came back and said, you know, the funny thing happened. My doctor, the one guy says, my doctor took me off theophylline. He said I don't have asthma anymore. Yeah, why are you telling me? Oh, it was that thing you did. No, come on, get out of here. No, it's the only thing that was any different in the last 6 weeks, so that had to be it. Then the other woman with the car accident comes in and goes, you know, my doctor cut my theophylline in half because he said my asthma is much better. So that's when I realized something's going on here. That was the neurofeedback end of it. I realized something's going on, and I then start looking at neurology's data about dementia because my mom and my grandmother got involved with dementia. So I started looking at that and saw that there's a very clear research base saying that slow wave amplitudes go up, fast wave amplitudes go down. And then I looked for the literature on what the neurology community had done with that data, and it was repeat the study over and over again. They didn't do anything. So then I looked at the literature in behavioral medicine and saw that a lot was being done on seizure disorder with neurofeedback. Well, gee, wouldn't the neurology community want to know something about that? And then I realized how many neurologists are reading the Journal of Biofeedback. So that led me to do a study on that. And in the middle of that study, we did a study showing that people who could learn to decrease slow wave amplitudes and increase mid-range amplitudes got better on the entire battery of normal neuropsychological testing, especially memory, short and long-term memory. So that made it clear to me that neurofeedback was a treatment for dementia up to a point. What we were doing was changing the slope of decline. We weren't actually treating the underlying pathology. In the middle of that study, one of the participants' husbands, who was a hardcore agro-business, agricultural biochemist, sends me a link to the Daily Mail in London. You know what that is, right? It's like the National Enquirer. I'm like, oh my God, what is he doing? He must be desperate. I open it up and it says, UK researchers reverse dementia using infrared light. And I'm like, oh, okay, no wonder. He'll go for anything. You know, I'm like, my sister was taken by aliens kind of thing. But then I read the article and I go, oh, wait. This is not one of their articles. This is an article about a paper published in the British Journal of Neuroscience. Oh, okay, all right. So then I go to the journal, read the paper, read the references, and I'm like, geez, they're not kidding. So I called the guy up and I said, well, I can't punch a hole in what they're doing. And the people who wrote this paper are like Caltech, MIT, European Union, you know, neuronal biophysics, big shots. Okay, you want me to go to England and get one of these gizmos for your wife? Well, see if they'll come here. This guy had a lot of zeros after his name. Okay, hi, you don't know me from a hole in the wall. What would it take for you to come to Villanova, Pennsylvania and put your gizmo on this guy's wife's head? 6 weeks later, we're doing it. 2.5 weeks after that, we're doing 2 sessions twice a day, 6 minutes each of the 1070 nanometer helmet. What happened next is my research assistant comes in tears after the morning session. What's the matter? Oh my God, they had such a fight. A fight? Yeah, oh, she was yelling at him and they were having an argument. I was like, what do you mean? She said, like, where do you get off making plans to go see our son in Oregon, you know, without consulting me? I'm like, hold on. This woman has primary progressive aphasia. Did all of those words come out of her mouth at once? Oh no, this went on for minutes. She was yelling at him for a while. In the middle of this, the phone rings. Hello? Oh my God, I can't believe it. She's so pissed. I got my wife back. Click. I'm standing there looking at the phone. What the hell just happened? And then it hit me that all the neurofeedback that we were doing had organized and kind of structured her pattern of or networking such that it was more efficient, but there was no energy in the system. And the photobiomodulation delivered the necessary information into the system. And once there was sufficient energy, then everything could kick in and you could see that this person could actually organize stimulation and process data significantly more efficiently. And back came her language, back came her emotional regulation, and back came her, where the hell do you get off not consulting me? So that was the beginning of the whole, oh, it's not one or the other, it's both. And so from then on, and that was 2008, I've been trying to work out how we can integrate this kind of photobiomodulation, which was specifically 1070 nanometers, which is above the usual range of near infrared stimulation, which usually ends about 850. So the reasoning behind that is, you know, has some validity to it, but one of the things you see in the peak curve of the absorption curve is that it drops off after 800 and something, drops off way down, but then it comes back up almost to the same height at around 1050 to 1070. So there was something going on there that wasn't quite observed correctly, nor was it investigated much at all. So I was working with the people who were investigating that at Durham University, Paul Chazot, and we started to see that there was a lot to this 1070 story that had not been told. So now roll the tape forward. I finally got to do a double-blind placebo-controlled trial with the helmet, with the infrared, with people with early to mid-stage dementia. And in 2 months of using it twice a day for 6 minutes a day, we got almost a 5-point increase in the mini-mental status exam, which is significant at many zeros. So that meant that we could influence at a tissue level the pathology, the dementia neurodegenerative pathology, but we could also then know that we could add the neurofeedback to improve the neuroconnectivity. So that brings us about around to where we are now. I mean, some people, well, where we are today is we've got this device called the Neuromatrix, and this is an identical device to the Neuradiant, which is the one that I developed and then formed a company called Neuronic. So I'm no longer working with Neuronic, and Neuromatrix, and the guy who's running Neuromatrix is Sanjay Machanda. And Sanjay and I are working together now on developing this approach, which has two significant differences. One is that the number of people who can use the device and have their own individual protocol is now 4 instead of 2. And the depth at which you can go in any protocol, you can go 9 steps deep, not just 4. And for different kinds of protocols, especially when you're trying to work with coherence and other kinds of complex protocols, it's good to have those multiple added steps, as well as if you're doing meditation work, you want to work in a ramping format, starting from low and going up into 1,000 hertz, 2,000 hertz and higher. So we're working on a meditation side, and we're also working on peak performance and also remediation and neurodegeneration and all the rest of the things that we deal with in neuromodulation treatment and working with people. So that's where we are as of today. This is the part where somebody asks me a question.
So, okay, I'll start off, Marvin.
Okay, Rob.
So let's you spoke about head injury as an example, and I agree with you. At least half the people I see, if not more, wind up coming in and either through mapping or through questionnaire. And you have my questionnaire, by the way. Marvin does have my questionnaire now, and he'll give you his thoughts about that if he's gone through it at some point in time. But it's pretty comprehensive. So we see a lot of that, and then we discuss cases here, and we'll see what appears to be head injury in the map, and these people are denying it.
Oh, absolutely. Leah, let me add one more, Rob.
Please.
One thing, the reason I'm on tonight and will be next week is that Richard and I have had a conversation about introducing and integrating the Neuromatrix into the New Mind community. And that what I want to do is support everybody in the New Mind community on how to use your existing approaches to assessment and intervention planning with neurofeedback, but then what would you do in order to augment the kind of treatment that you want to do with people, and also what kind of other support can you provide that isn't neurofeedback specific, but is more energy specific, and then how would you use the photobiomodulation, the transcranial photobiomodulation, as well as intranasal, because a lot of people brought up the issue of intranasal stimulation. So I went back to the people who make the Neuromatrix, and I had them design this, which is a 2-probe, 80 milliwatt, 1070 nanometer intranasal stimulation program. And I think you can see that pretty well, right? Well, there it is.
Yeah,
so
that's clear. Yep.
So it has different levels of intensity, 25, 50, 75, and 100% intensity. You can also control whether you do one nostril or the other. And you can control how long you can have the stimulation going on, like 15, 30, 45 minutes. What I've been interested in is using this, especially with people with long COVID, brain fog. And what we've seen is that it works to regain your sense of smell and your sense of taste and eliminate the brain fog. Now, we saw that also in a clinical trial with the Neuradiant device, remember the identical one to this, we did it, Bob Bowen and Praveen Irani did a study on that and published it a couple of years ago. And they compared putting people in the Thor bed, you know, the whole big bed, the $100,000 or more bed, and the Neuromatrix. What they found is that if you did 14 minutes 3 times a week for a month, at the end of the month, you didn't have long COVID. So
Yeah.
everybody in the sample, both groups, completely remitted of symptoms.
And those 3 symptoms, if I can add to what you were saying, are classic symptoms that can feed the whole process of moving more towards Alzheimer's and dementia, right?
Absolutely, absolutely.
And the reason I brought up head injury for you, because we see it so much, but with that, we've seen here that with head injury, we expect to see one or more of the following: poor sleep, anxiety, depression, and then cognitive processing deficits. Those are very typical, common things we'll see here and discuss, and almost everybody has poor sleep.
Yep. And so the point here is that 85% of the reason there's life on Earth is because of near infrared light. Try living without it. So what happens when we're traumatized on any level is that our central nervous system starts to function less efficiently. To the degree that it's functioning less efficiently, we are getting poorer gas mileage than we did when we didn't have any injury. So what that amounts to then is we are running at a deficit, and then we're doing things to ourselves to alter the coping mechanisms that we have, which means that we're now adding a further level of stress to the system, even though we call it therapeutic. Now, what that means is that people then have trouble making good use of the therapeutic interventions that we're providing. Now, I don't know how many people are familiar with Dirk de Ridder's work, but Dirk has been publishing on neurofeedback in Nature for years now, and he's shown, and now in his current talks that he's giving all over, he's talking about how people respond very well to neurofeedback training, but then 2 to 3 weeks after they do the training, they crash. And what he said after he and I spoke was that, yes, what they're doing is they're running out of gas. They're losing energy. They don't have enough energy to sustain the improvement that they made during the neurofeedback. And I said, well, maybe we can think about this as the gas station. And that what we want to do is provide front load energy into the system by delivering photonic energy, which then gets converted into adenosine triphosphate, ATP, and that's the gasoline for everything in the body. So why don't we add gas to the tank and then start adding in the neurofeedback, the neuromodulation, to renormalize the connectivity so that the capacity, the system's capacity to sustain a higher level of energetic charge, if you will, is created. And then people can make continuing good use of the neurofeedback because it then becomes self-reinforcing. The neurofeedback becomes self-reinforcing because it's continually increasing the efficiency of the CNS. So that's my pitch, as it were, for why we want to integrate EEG assessment with photobiomodulation. And that's what Quiet Mind is working on now with research partners at Santa Clara University, University of Texas at Arlington, Baylor Scott and White, Texas A&M, number of other, and North Central University in Minnesota, where we have an actual neuroscience laboratory where we're conducting studies using functional near-infrared spectroscopy and quantitative EEG. But the point is to maybe put the EEG in the helmet so we can actually record at the same time as we can then deliver stimulation. But we can have an AI maybe algorithm that will take the EEG data and have that control the delivery of the lights, both in terms of amplitude, Z-scores for amplitude and reduction of, well, even with the NeuMind model, we can use the same the matrix and algorithms that Richard's developed to then modulate the delivery of the light. Whether it's Z-scores or whether it's the NeuMind algorithm, I honestly don't care. I just want to produce the result as a clinician.
Marvin, people often ask me, should you do the helmet before, during, or after neurofeedback? That's the most.
That's simple. Yes, that's simple. Yeah, that's a simple question. Yes, yes, yes.
I thought so.
Yeah, either or questions usually get a both response from me. But the point is, I very much want to encourage people to resist the impulse to protocolize.
Yeah.
I know there's a strong seductive urge to do that for all sorts of reasons. And I just say, let's resist that urge at the moment and start to understand what it is that the client actually needs in that context that we're in, and do what it is that we need to do in order to meet that need, and then add a nudge. So the principle I would like to sell at the moment is meet the need and add a nudge. And whether the nudge is, a different wavelength, a different frequency of photobiomodulation, or a different protocol for power training or coherence training or phase training, I don't know. But I think that's the conversation I want us all to be in together as we start to bring these pieces together. So I definitely will advocate for before, given everything I just said about putting gas in the tank. I will definitely advocate for the before, yes. The during, maybe, and after, maybe. But I'll leave it at yes, maybe, maybe.
Yeah, that's what the people using your technology in the clinics have said. They've said they do it before, and that seems to help the session tremendously. And in our group, everybody is really promoted the concept that everything should be individualized, and you tell if it works by watching the trend screen. The trend screen tells you, is it brain normalizing? Is it going in the right direction? Or is it not? And that's how you know the empirical results. So we always emphasize.
And one of the things I've made a habit of is in my initial assessment and training with people to say, how sexy are those squiggly lines that I showed you? How much does that like thrill you? Not much. How about those circles with the colors in them? Does that really like float your boat? No, not really. Yeah, see, those are for me. Those are not for you. That's what gets me all, but not you. So how about now you come up with 3 to 5 real world metrics that are going to tell you that this is working. So you need to come out with, how would I know, like if Marvin waved his magic helmet over my head, right? Or anywhere other part of my body, what would happen that I would go, oh, it worked?
Yeah, your slow waves would diminish in a lot of cases, and the fast waves would increase because the brain has more energy.
Yeah, but Mrs. Slobomowitz from Brooklyn could give a good you know what about slow waves.
Oh yeah.
She wants to know that she's not going to burn the kreplach for Shabbos.
Yep. Well, she gets a star in our system. She gets stars at the end of the session because the all the metrics are shown on a graph which produces stars, and she can count her lucky stars at each session.
So we
And
need
she
to
will like
add,
that.
yes, but we need to add number of kreplach not burnt.
Yeah, well, you get 3 stars. Your Krepla are not burnt.
There we go. So something has to translate into real world metrics. And those are the kind of things that people are going to respond to in daily life. The metrics that you're using in the New Mind assessment are terrific, and they speak to what it is I'm getting at. And what I want to do is push it one more step out into their life. So
Right.
you have real world, real life metrics, right? I didn't forget the appointment that I had. I remembered to pick my kid up from school. I studied for the exam and passed it, that kind of thing.
Yes, so people can choose on the symptom tracker we have what they want to track, and they can keep notes in there too.
That's exactly what I was saying. They can use the tracker to do exactly what I'm talking about.
And that's what we use to maintain clients, because they say, well, nothing's changed much. And then we show them the tracker and we said, well, you said this and this and this in all the sessions. It's gotten a lot better. And then they go, oh, you're right. I can get up from the couch and turn off the TV, and I couldn't do that 2 weeks ago.
Oh, that, right.
Yeah, it's really important.
I could eat my dinner without half of it landing in my lap because my hand was, because my spoon wasn't shaking so much. Oh, that.
Yeah, well, people forget very quickly what they've gained back.
Right. So this idea, and it also is about pushing the authority, the locus of authority back on the client, and really amplifying the importance of developing internal locus of control.
Yep, that's another thing we often talk about, is that as a client heals, the locus of control goes from outside to inside. That's a real sign that they're.
No, it's and there are measures, in the psychology literature about how to do that. But the story that I always tell is the little kid in the intensive outpatient program in Philadelphia, who I was doing neurofeedback with a bunch of these kids who were sent to outpatient therapy 3 times a week because of their disruptive behavior and all the other stuff going on with them. And this was in the Windows 95 days with the little jet plane. Remember that?
Yeah, I sure do.
This kid, I almost cry every time I tell the story. This kid sat there watching the plane hooked up to the EEG, and he's looking and he's looking and he's looking. He's like, wait, am I making that happen? Is that happening because of me? And I went, yeah, that's you controlling the computer with your mind. And he sat there and looked at it for the longest time. And of course, his scores got better and better. But it was clear that he was having that moment of going, wait, I'm having an instrumental impact on my environment. And it was clear that he never conceived of himself that way before then.
Yeah,
and I was like,
moment.
if neurofeedback, literally, I said, if neurofeedback does nothing
else, yes.
If it only does that, I'm doing this for the rest of my life.
Yeah, that's a very good point. And that's one thing about cybernetics that people miss or disregard. the importance of the human to affect the machine directly and control it, with their mind. It gives you a sense of power and control and effectiveness, really, efficacy.
So, gee, I wonder why there's so much ambivalence and anxiety about AI.
Yeah, really.
Yeah, don't get me started on that one.
Well, we're all
Headed that way fast.
it's on us to discuss that as a clinical issue in all of our practices. And I think it's important to look at it from this perspective of internal and external locus of control. And what are the implications clinically for encouraging people to continually surrender that control over to something else, or at least labor under the fantasy that that's not what they're doing.
So, a quick question for you, because I know we're close to the top of the hour. So, what's for next week when you come back on Monday? When people have questions like, okay, let's say many of our people will start off with a person who's got a sleep issue, and we'll start off doing some basic training. I think you're not doing this at SMR, at CZ or C3, C4. So
Right.
will you be addressing how to set that helmet in terms of the parameters of the
We
frequency
certainly
based?
can do that. I
That's
would
going to be, I think, pretty helpful.
I would want people to bring a bit more clinical material, a little more of a clinical picture of the person, especially family system issues, family system dynamics.
Okay.
Yeah, and obviously head trauma or other, general anesthesia is something that sometimes people don't think about as a head trauma. I know you guys, cue in on that, and it's important.
Tonight, of course, we have part 2, as advertised, with Marvin Berman. He's the CEO of Quiet Mind Foundation. Part 1 last Monday was about the neuroregulation, neuromodulation helmet that he works with, and he did some overview stuff. Tonight, we're going to be going over 2 different, well, at least 1, possibly 2 different maps, and he'll show you how, from a map, look at how to do the settings on the helmet. So Marvin, it is all yours.
Hi, everybody. Good to be back. I am assuming you're all here to pick up where we left off last time. One of the things that I think I got into but want to expand on is the fact that Quiet Mind, our approach is definitely very much aligned with NewMind's model in terms of being kind of a three-legged stool with neurostimulation, functional medicine, and neurofeedback. And I want to reiterate that photobiomodulation is one part of an intervention strategy, and that's why I think it's important for the people who are using the NewMind approach to seriously consider incorporating photobiomodulation as a tissue level intervention that will increase the brain and central nervous system and the body's ability to make use of neurofeedback interventions and other kinds of interventions, because what we're doing is feeding energy into the system, literally. And photobiomodulation is the only neuromodulation intervention that is both nutritive and therapeutic. So that's how we're going to be thinking about it tonight. The other principle that I want to start with and continue with is the idea that trauma causes a contraction of some sort in the organism at every level in the organism. so that one way we can track the impact of trauma is by looking at contraction, or the process of contraction, at every level in the system. So in the neuromuscular system, we can see chronic patterns of muscular tension. In the EEG, we now can start to see changing patterns from norms of the EEG. We can also see decreases in amplitude in fast wave activity and increases in amplitude in slow wave activity. We can also see it psychologically in terms of cognitive slowing and other forms of changes in behavior and expression. So that pattern of contraction is something I want to share as we talk about both how we understand the impact of trauma on the EEG, but also how we would then use the Neuromatrix device to remediate that kind of deficit. Because we're always looking at the impact of trauma as causing an energetic deficiency in the system, because it's going to change efficiency, and therefore it's going to make it important to introduce energy into the system, as well as help to remediate and renormalize connectivity in the EEG. This is my way of understanding our goal in neurofeedback and maybe even life. That's my little buddy there. But we're all trying to become a smart rat. We're working on becoming a smarter rat. So I'm just going to pick the dominant frequency and coherence to look at the impact of a guy, middle-aged guy, who had a head trauma, and otherwise was a pretty high-functioning individual. And what I saw in the map is the fact that you see a very high dominant frequency in the alpha range. And while on the one hand, we like to see a peak alpha dominant frequency somewhere in the 10 hertz range. But Richard, I was going to ask, is there a way to quantify, can we get the quantity value of the dominant frequency? The actual?
Yeah, you have to print those out separately. If we'd known you wanted them, I could have had them, but.
That's okay. So we can get the numeric value, but the point is that with a fast dominant frequency or an abnormal dominant frequency, we want to be able to either raise or lower that dominant frequency to bring it more into the normal range.
That's pretty close to 12 hertz that when it's that high up on down in the middle.
I was thinking it was probably up there. So the point is that because we have the ability to independently program front, back, left, and right in the Neuromatrix, we can then nudge the dominant frequency up or down. So in this case, we could set the protocol first to provide energy to the system, as I was saying last time, to give energy to the system so that we are increasing the capacity to tolerate change. So any therapeutic intervention involves the introduction of change, whether it's one up, training up or training down or fast or slow, it doesn't matter. It's that we're introducing a change into the system. And by doing that, we're making an inherent demand on the system to function differently. And that, therefore, if you're asking an already inefficiently functioning system to then make even more change, even though it's, quote, therapeutic, it's still making a demand on the system that's already in a state of depletion. So my suggestion is to always start with feeding the system energy directly by using the no pulsing 0 hertz 100% duty cycle setting in the Neuromatrix for at least 3 to 6 minutes to begin with. then you can know that the system has more energy to work with, and now you can introduce slowly and deliberatively. You can put changes into the system that the system now has the capacity to tolerate better. So, with that in mind, we can introduce slower frequencies like 8 to 10 hertz. And you can see the theta values are pretty low. So we can add something into there. And we see that the left-sided beta is also kind of low. So we can add, say, 8 or 10 or 12 hertz to slowly nudge the system to respond a little faster and a little faster. Because we know, again, that pulsing light on the scalp will cause an entrainment response in the EEG. Any comments, questions up till now? You can interrupt me, it's fine.
I think that's a really important point and an essential concept to Neuromatrix, is that it induces entrainment. It creates entrainment, and it works similar to entrainment glasses, but it's a different technology because it's putting energy into the brain in a way that you usually aren't with the glasses.
Right. Photic stimulation, any other form of stimulation, is making an inherent demand on the system to change. It's introducing a difference. And so we want to make sure that the system is optimized to be able to make good use of that therapeutic difference that's being introduced.
Do the beta waves literally go up then? Like the neurofeedback heads would look different?
Beta power, and yeah, beta power will increase. Okay. Okay.
Yes.
Anybody else?
Oh, that was really clear.
Okay, great. So given that what we're doing is introducing support, initial support to the system, we can then add a nudge because we've now met the need and we're adding a nudge to the system. So looking at the data, you can begin to formulate a strategy for protocols for the Neuromatrix. And remember, you've got 9, you can go 9 steps deep. I do not encourage people who are starting out with this to go more than 2 or 3 steps into the protocol to begin with. That's plenty in terms of getting good responses and good clinical results. Going further into that is, down the road, we can certainly start talking about what are the kind of protocols that you might use more and more steps with. Certainly one of them would be in terms of modifying coherence. But where we are now, 2 or 3 steps deep is going to be more than enough.
An unfamiliar term is steps for everybody. Can you help us understand what that means?
I'm assuming you can see me, is that right?
No, we can turn you on.
You can't see me. Oh, so the Neuromatrix has protocols, and there are 4 programs that can be independently set up for 4 different clients. And you can then, inside each of those programs, there are 9 independent steps that you can program in so that you can start with one, like I'm saying, you can start with 100% duty cycle, or in this case, 100% intensity. And you can then move to 8 hertz at a lower intensity, 10 hertz, 12 hertz, 20 hertz. You can do that all the way down 9 steps deep. And you can pick where you want the stimulation to be, on the left hemisphere, right hemisphere, frontal, occipital. You can select at each step what kind of pulse frequency you want in which quadrant and what intensity you want in that quadrant, and for how long overall are you going to then deliver this particular form of stimulation before moving on to the next one. So that's what we mean by steps.
Yeah, events or segments that are linked, you know.
Right. And these are automated so that once you set it up the way you want it, all the client is going to do, if they're doing this on their own, they're going to basically open up the software, open up the controller, they're going to go to their program and they're going to hit run. And then everything else is fully automated. Because we're dealing with people, in my case, when I first started doing this, we were dealing with people who had early to mid-stage Alzheimer's and Parkinson's. So we had to make sure that it was pretty close to idiot-proof. Okay, so what I want to share here is the similarity between the coherence measure in the new mind map and the coherence measure in the NeuroGuide summary. And what we're looking at in the new mind, you can see that there's a very clear pattern of hyperconnectivity or hypocorrelation front to back. And so this is the left hemisphere and the right hemisphere functioning too much the same, with less flexibility than one might want in terms of how information is being processed. So that is an extremely typical and expected response when somebody sustained a trauma. The brain regresses, if you will, to an earlier, less energy demanding algorithm of organization. And that pattern is decidedly homolateral. So you sacrifice interhemispheric connectivity for a more basic model for processing information that's what we all used from the time we were born till the time we were 10 months old. And so it's a normal, necessary pattern of, or algorithm, if you will, of information processing that's in us, that is something that we mature out of, just the way we mature out of certain primitive reflexes. We mature out of this more primitive algorithm for processing information that has to do with homolaterality and moving toward more bilateral processing. So what we see in the EEG, in the coherence maps in NeuroGuide, is 3 standard deviations of bilateral hypocoherence. That's the blue. What we see on top of that is a very clear 3 standard deviation bilateral pattern of hypercoherence. So the hypercoherence is now compensating for the hypocoherence that was created by the impact that this person sustained to the back of their head and to the left side. So that's that. I just wanted to give that as a framework for how we're working. Now, in terms of amplitude, one of the things that gets picked up in the map is this occipital hypo deficit in amplitude in beta, high beta, and in theta. And I'm sure that this gets picked up in the new mind maps. I'm not as familiar with it that way, but one of the things that I caution people about when I see this is to not mistake this particular pattern of diminished activity as being specifically brain activity, but could be the result of a subluxation in the C1 and C2 vertebra at the top of the spine. And so it's important to make sure that that particular problem is evaluated and treated before you start determining that what you're looking at is in fact brain activity. And in fact, in this particular case, when I brought up that fact, the client told me that he's now working with a chiropractor who is very aggressively working on renormalizing his upper cervical spine. So this is electrophysiological, diagnostically significant information that would have you referring somebody out for upper cervical or Atlas orthogonal chiropractic or functional neurology, something where they're going to work with the upper cervical segment of somebody's spine. Okay, so that's it for me here for this map. Rob, do you want to?
Now on that, yeah, I'll give you another map, but on that map we were looking at was the Z-score summary. That's NuMind. When you look at NeuroGuide, is NeuroGuide reflecting the same power that the NuMind map has?
Close. I
Well,
mean,
can we see NuMind map power on that in the same case? Then I wanted to compare it to.
Yeah, it looks almost identical, Rob.
Oh, okay.
It looks pretty much the same to me.
If you here, I'll show you. I'll turn the screen over to me, and I'll just real quick show you just so that you can see.
Yeah, that'll be helpful, I think, for me and some others, hopefully.
Can you see that?
Oh, yeah, there it is. And there's the hot spot there. Gotcha.
Yeah.
Yes.
She had, on the NeuroGuide, the same spot showed up. I mean, that's how definite on both maps it showed up exactly the same. Although, of course, there's more theta in ours because ours shows theta more strongly than NeuroGuide, just because it's slightly different in processing. But
no, that makes sense. Good. Now that makes better sense to me. Thank you.
Okay, shall I turn it over to you, Rob?
Yeah, give me the screen and I'll bring up my map.
Great. Any comments from the rest of the group?
Yeah, questions, comments?
Okay.
So
Do you see my map?
Question. Oh.
Yeah,
we got somebody.
Okay,
yeah,
good.
I have a question. So when they're wearing the helmet with this light, how far deep does it penetrate through the skull, or how does?
Light at So you remember from Halloween when you used to take the flashlight and put it in your hand?
Yes.
And you could see the red through your hand?
Uh-huh.
So we all know that light can penetrate the body. So with that in mind, the light coming out of the flashlight is at a much lower wavelength than the light coming out of the helmet. The helmet wavelength is at 1,070 nanometers. So that's above the visible range. So that wavelength of light can penetrate fairly easily through the skull, which of course is a crystalline structure. So you've got actual tubular, almost like piping that allows the light to pass right through, kind of like fiber optic, but it's the structure of the bone that allows the light to pass through with very little interference. And then you've just got the dura mater, and then you're into the cortex. So depending on the power, the wattage of the light, you can penetrate with the 16 watts that the Neuromatrix is putting out, you can penetrate between 1 to 3 to maybe 5 centimeters into the cortex, which means that you're going to hit 80% of the pyramidal neurons in the cortex. If you then use the intranasal device that I developed that has 80 milliwatts of infrared 1070 going right up your nose, that light is going to be penetrating directly into the cribriform plate and through to the frontal lobe. That, I don't know how deep that can go. If you do it in the back of your head through the piriformis, you can get probably somewhere into the lower part of the cerebellum. So you can get a lot of penetration with this, is I think the short answer.
Thank you.
Sure.
All right, well, here's eyes closed on this map and your dominant frequency there together. And last head injury on this person was in the posterior, hit hard. It really, I mean, it was like, it moved hair the way she fell. So P3 was, if you wanted to say where did she hit, P3 was where she actually got hit. She fell down and hit a staircase, a brick staircase.
Wow.
So,
What do you
Bob,
think?
do you have the topo and the sliders?
Oh yeah, yeah. Let me go back up. I gotta just, I gotta move my little screen here around. Okay, so here we go.
And
That's what you want.
yeah, that'll be easier on Marvin.
Oh, yeah.
He's used to looking at topos.
Okay,
You can
gotcha.
see that alpha's all the way down, and frequency's probably below 8 hertz. It's slammed all the way to the left.
And the extreme temporal and occipital delta.
Yeah.
So
that.
this again, this is another great example, Rob, of muscle contraction influencing EEG or influencing the appearance of the map. So it would be extremely unlikely that someone who sustains the kind of head trauma that you're talking about, that they didn't lock their neck back and lock their jaw and grit their teeth.
Right.
Well, they got EMG around the jaw, left side. You see it, the high beta, that's EMG there, and
Right.
around the
So
back too, just like
we
you said.
always want to be, making sure that we're interpreting out the EMG and referring out for that kind of for resolving that issue to some degree.
Yep. Yep.
But the extreme beta and the low dominant frequency. So this would again be somebody that we would want to nourish their brain right off the bat and provide continual nurturing stimulation that will hopefully let their body feel safe enough to begin to let go of the accumulated trauma response, which would then help in reducing the EMG artifact, as well as all the other symptoms that come along with, chronic jaw contraction.
Yeah, this one has a slow stuff, the other one's slightly fast. How would you operate the steps and that kind of thing? Would you start again with putting just energy all over in at
Certainly,
the beginning?
well, energy all over up to SMR.
So in the
And
older helmet, I have the older helmet that has the little, box where you can set your hertz and all that.
oh yeah,
What hertz would I want to set it at?
well, if you would set that, you could set step 1 to be every 0 hertz, just continuous stimulation.
Okay.
And then you could do something similar where you could do 8, 10, 12, well, 8, 10, 14. Because you've only, how many steps do you have in the one you have?
I'd have to go look and see. I don't
Well,
understand it from my
you can
steps. I
see.
I know I can set the hertz on it. So
Oh yeah, we can set the hertz on any of them, all of them. That was
okay.
one of the primary. That was one of the primary features of the Neuradian and now the Neuromatrix is you can set the pulse rate of the light from 0 to 20,000 hertz in each of the
Gotcha.
quadrants at 25, 50, 75% intensity or duty cycle. And again, duty cycle means that the light will stay on for a percentage of the time that it could stay on during each on phase of the pulse frequency. So when the light is on, before it turns off, that amount of time that it's on can either be, you can set it for 25, 50, 75, or 100% of that time would be active and on. So that's one way of controlling the intensity of the stimulation that you're delivering, along with the fact that you can dose the light for a certain amount of time in terms of in minutes. Is that enough?
That makes some sense. I'll have to go back and look at the helmet, and if I have other questions, I'll just email you.
Okay, that's everybody can just email me, their questions after we're done here, or just give me a call.
Right.
Because I'm decidedly supportive of everybody getting serious about integrating this into their treatment model. There's a lot of research that the foundation wants to do, and in order to do it, we need more people, clinicians, using this technology who have the ability to do topographic mapping.
Oh, this is great though, Marvin. It gives us a sense of how the technology, how you generally implement the technology with neurofeedback. And it's really
Sure.
quite, it's not anything too over your head. It's pretty straightforward. And,
Yeah, I mean, it better be, or I wouldn't be doing it. I mean,
well, there are some people out there that get really fancy, complex technology, which, it takes like a year or two to learn how to work it.
yeah, well, being from
And
New
so,
York, there's a kind of baseline cut the bullshit. Let's just get on with it.
well, it's good because it encourages people to use
Yeah,
it, not be
this
intimidated
is
by it at all.
this
It's
is
a new
not rocket
thing.
science. Yeah, I mean, it's safe, and B, it's straightforward.
Yeah.
And so we're not doing anything different than we would do in psychotherapy, right? And I mean, regardless of the school of therapy, you're establishing a therapeutic relationship, and in doing that, you're essentially creating a transference relationship with the client in which there is an alliance that we're going to, try and meet your needs. Well, that framing of we're going to work on meeting your needs and your goals, that's the same principle that's being employed here by delivering continuous light stimulation into the brain. We're meeting the need that was created by the trauma directly, energetically, biochemically. It's the same thing. It's just we're looking at it at a different level of analysis. That's all.
And with this TBI case, we'll probably see that alpha dominant frequency creeping up over time.
Oh, certainly that's going to be the anxiety and the resistance, the anxiety and resistance to change. And I mean, this would certainly be the sort of thing therapeutically that you would want to work on, kind of critical incident debriefing, EMDR, those kind of, trauma reduction interventions, but having the person be able to work through the trauma without re-traumatizing themselves.
Yeah, that's a really good addition.
It's
to
very important.
neurofeedback.
Yeah, it's very important. And that's one of the reasons why I'm talking about this idea of meeting the need and the 100% stimulation, because we want to provide resources to an already traumatized system so that we can basically buy insurance against re-traumatization. We're hedging, it's like a hedge against re-traumatizing somebody by having them, you know, reconnect or relive the trauma.
It sounds like to me like in some of the original research, they didn't run entrainment frequencies. They just ran the infrared
With
on
the
head.
Yeah, the study that we did in Texas, there was a pulse rate of 480 hertz, which is a harmonic of 40, and that was the only pulse rate in the system, and it was a much more higher wattage intervention because the device that we were using was the precursor to the Neuradian, let alone the Neuromatrix, and that was the device that was developed in the UK called the Cognitolite.
Yeah,
that
that's
was
the one I'm referring
yeah,
to.
that was a much higher powered device that was also intraocular. So you had arrays that were directing the light directly into the eyes as well as all over your head.
And they were working on people with dementia, weren't they?
Early to mid-stage dementia, and there was a secondary cohort of subjects in the Texas cohort who were duly diagnosed with Parkinson's and Alzheimer's.
Right.
And at the end of the study, they interviewed the families, you know, the kind of exit interview, and the families of the people with Parkinson's uniformly reported significant improvements in all the major Parkinson's symptoms. Gait stability, fluidity, masking, apathy, memory, socialization, everything significantly improved.
You got a globally positive response. That's great.
Well, yeah, because,
how fast?
well,
It was
yeah,
pretty fast, wasn't it?
It's a systemic, I mean, this is why I know I keep trying to make the point that this is a systemic intervention.
Yeah.
This is not a molecule looking for a receptor site.
Mm-hmm.
That's not what we're doing.
Yeah, well, we try to think of the brain as a system, and training areas of the brain is just intervening at the best entrance into the system as it is, you know.
Right.
I mean, you can think of it that way. This way you can do the same thing. You can pick quadrants and which one is the best intervention.
Right. And it will change. And the other point is that because people are going to be doing neurofeedback, they are going to be collecting data about the impact of the photobiomodulation intervention along with the neurofeedback, so that over time you can then start to look at the changes in the neurofeedback and modify the light therapy and to continually support the improvement that you're seeing. So they work, hand in glove.
Yeah.
That's why I strongly recommend that when people are doing this, that they consult with me in a kind of clinical supervision framework so that we can look at the 10, 20 sessions of neurofeedback and photobiomodulation and then say, okay, well, here's where we are now. How do we modify the protocol now in order to take people even further into optimizing their performance?
No,
Doc,
on
may I
the,
ask a question?
oh yeah, please ask.
So I missed last week, so apologize if I'm, just need to go back and watch that other video. Dr. Berman, I've watched a few of your videos on the treatment of the dementia patients, and you recommend twice a day. I think the study may have been twice a day for 12 weeks.
Yep.
And what we're talking about tonight is this only for trauma, or is this for any neurofeedback patient?
That was a really good. I'm really glad you missed last week.
Okay.
But no, because it's very important. Because I'm saying, and I hope that my saying this is a systemic intervention maybe stimulated your question, because it's really important to step away from the diagnosis specific strategizing for this intervention. What we're doing is intervening at an energetic level in order to enhance the efficiency of the CNS. That's it. So if what we're doing is enhancing central nervous system efficiency, then the question, the more relevant question or appropriate question is, if whatever the disorder is that you're concerned about or that you're seeing, if it's in any way mediated by the central nervous system, the question then becomes, what wouldn't improve?
Right.
Because it's a systemic intervention that's making the CNS work more efficiently. And by efficiently, I mean literally burning less calories in order to accomplish the task. This is second law of thermodynamics stuff here.
Okay. So is the twice a day still a recommended frequency for?
No, it is not recommended.
Okay.
It is important to note that people can benefit from using the device more than once a day as they are capable of tolerating that level of stimulation. So you're always going to be looking at the capacity for the system to tolerate and make good use of the additional stimulation, right? So that, with that in mind, you could do once, twice, 3 times. I did it 4 times a day when I was down with COVID in 2020. And it's the reason I didn't have to go to the hospital and get intubated.
Okay.
So but I knew what to do, right? And I had the resources to do it. So that was for COVID, but I've used it with people 2-3 times a day, but not after dark, not after sundown. Again, this is sunlight being delivered into the brain. During what part of the circadian rhythm do you get sunlight delivered into your brain? When don't you? So for 200,000 years, it's really been one way. So I would tend to lean into that general principle. So you want to stimulate during the daylight and you want to not stimulate during the night.
Kind of like not doing beta to theta ratio before you go to, theta to beta ratio before you go to bed, Not
Same thing.
Yeah.
Same thing. I get really boring because I keep saying it's the same thing.
That's okay. As far as there is some, there is a quadrant function in the Neuromatrix.
Yep.
So location, to some degree, in a very general way, has an impact and plays a role in it.
For sure. And we can then begin to look at doing stimulation of one type. In this case, we could do more beta stimulation in the front, but not at beta. So we know we're going to be doing frontal stimulation right here in delta, theta, alpha, and even high beta. We can do some quadrant related work there. We definitely would not want to overstimulate the occipital. So we could just turn on the frontal area and leave the other 3 off. And, you know, something, and just like that, we could also, because of the EMG issue, I'm not going to do anything specific. We have another map, Rob? We've got 10 minutes. Do we have another map?
Yeah, I can try to pull up one
Well,
real
if
quick.
we don't, I mean, the point Richard's making is important. I mean, when we start working with the quadrants, one of the things that you can take as a starting point is going back to what I was saying about the coherence, the homolaterality and bilaterality of the coherence, and that what we might want to do in terms of increasing or normalizing coherence, what we might want to do is then set the pulse rate of the left hemisphere at 1 rate, and then set the pulse rate of the right hemisphere somewhat above or below based on what we see in the map. So if we know that we've got a lot of, in this case, hypocoherence in the central and parietal region, we see that range of hypocoherence is predominantly in, say, 5 to 12 hertz. We could set the left hemisphere at 3 hertz, the right hemisphere at 16 hertz, and we could stimulate for 2 minutes that way. And then in the next 2 minutes, we would flip and have 16 in the left and 3 in the right. And then do that for 2 minutes and then flip it back and flip it again and flip it again and flip it again. So what we're doing in that instance is we're re-stimulating interhemispheric connectivity. And we're broadening the range of frequencies that we're going to be in training greater than the range of dysregulated or stuck frequencies that we're seeing in the map. So we can do something similar to what primitive reflex people are doing when they train with bilateral cross crawl and movement across the midline. So when you're doing that kind of with Parkinson's people, they're doing rock steady boxing, and they're doing all kinds of bilateral movements. I recommend people go to YouTube and dial up something called Brain Gym, and those are exercises back from the 70s by Paul and Gail Dennison, who created something called edukinesthetics for kids with learning and reading and attention issues. And they had these kids doing cross crawl, bilateral, but crossing the midline movements and getting phenomenal results, because what they were doing was reducing the hypo and hypercoherence that had been established by whatever the trauma was that the kids were dealing with. They were helping to remediate that by increasing and renormalizing coherence.
I'm very familiar with Brain Gym. I used to do it for years with the kids when I was running programs at an adolescent facility. So I know it quite well. Yep.
That's great. Well, I think everybody would be well advised to look at the edukinesthetics literature, and there's the primitive reflex literature is really important. The Feldenkrais movement, Feldenkrais awareness through movement technology is, I think, the most useful approach of all of them. And I was lucky enough that I trained with Moshe Feldenkrais back when he first came to the United States in 1980. And I've worked with a number of the people in the Feldenkrais Guild for 40 years. So I'm very, very pro Feldenkrais awareness through movement as a way to augment the work that we're doing from the inside out. They're doing that work from the outside in.
Kathy, you were going to say something?
Yeah, I mean, I think it could be good, you know, if you want to do some kind of little workshop on some of the movements or what they do, or I could. We use those all the time after
Perfect.
neurofeedback, even for a couple of moments. I mean, we sometimes do it differently. I used to teach it, but the you know, and we use the lights. I haven't dug deep into specializing with the photomodulation, but you know, we
That's
have
what I'm doing
it,
here.
and I know I'm just saying that I should, but you know, we do all this, and if people don't, I just so want to encourage it. It's so incredible for brains
Thank
that,
you.
you know, it makes me look so good. So, you know, I get farther, better, longer, quicker. So anyway,
That's
and you
good.
present it very well. I really appreciate it, Marvin. So
Oh, you're welcome. And you know, there's obviously this is a beginning point for all of us. I mean, there's way more questions than there are answers. That's for sure.
Hey, Marvin, I have a question.
Oh, goody.
So can you tailor the wavelengths? Well, there are two general ones, right? That the Neuromatrix uses 810 nanometers,
Only 1070.
only 1070. All right. And another
Light
question.
only uses 810.
Okay. And when it comes to the quadrants, you're talking about the left and right hemisphere, but is there an option, you know, to do front and back and be able to separate those?
Yep. You can separate any one of the four quadrants as you wish. So you can turn on left only, right only, front only, rear only, front and back, or left and right, or whatever you want.
Oh, okay, thank you.
It all depends on what we're trying to accomplish.
Anybody have any more questions? They're all stunned by your
Okay, everybody wave.
device, Marvin.
Take a deep breath through your nose, out through your mouth.
Okay, well, we're at the top of the hour.
We're at the top of the hour. Let me just add one more thing, and that is from a trauma treatment point of view, one of the things that I think is really important on a body level is getting the capacity for spontaneous movement and expression back into the body. And for that, I highly recommend something called bioenergetic analysis or bioenergetics. Just something from a long time ago, but it is a very effective method for getting people back into their body and being able to discharge the chronic muscular tension in the body. And if anybody's interested or has clients that they want to discuss about that, I was certified in bioenergetics in 1983.
Wow.
So
Okay.
thank you, Richard. Thank you, Rob. I really enjoyed doing this.
Yeah, thank you, Marvin.
Thank you,
Hope
Marvin.
we get to do
Yeah.
it again sometime.
Yeah, very
We'll-
clarifying. Oh,
I'm
yeah.
sure we'll have you back because your technology will continue to improve. You'll have more science and we'll continue to improve and have more information and we'll make it work.
And if anybody
so much, guys.
wants to get the Neuromatrix, they can call Victoria at New Minds. She'll get you set up with one and get you connected up with Marvin.
Yep, and the intranasal device is available now too. If anybody has anybody with long COVID, certainly that's one area we're studying. But if people want to include the intranasal device, they can have Victoria get them in touch with me.